So for the C-spine rule, it has to be a trauma patient, and they stratify the age, older than 16, alert with a 𝐏𝐨𝐝 scale score of 15, that's perfect, and with stable vitals. So the exclusion criteria, just meaning that the literature they pulled this from, the cohort they pulled this from, do not have anybody in it younger than 16. If you had a 𝐏𝐴 score less than 15, if there were other injuries, abnormal vitals, or if the injury was more than 48 hours ago. And then they went on and on to be really specific. No penetrating trauma, no acute paralysis, no pre-existing known vertebral disease. So it's nice to mention that there are rules to this. But again, these clinical decision rules, like any rules, apply to the majority of patients. There's always going to be outliers and exceptions. The Canadian cervical spine rule is 3 questions. And that sounds really nice. But in reality, this rule is kind of unwieldy, and it takes some getting used to. The first question's easy, and usually you can stop right there, which is nice. So the first question is, are there any high-risk factors that mandate radiography, including the patient's older than 65, they had a dangerous mechanism of injury, or has paresthesias in their extremities? So if you had yes to any of those, they get radiographs. So that's really neat. So older than 65, they had a dangerous mechanism of injury or have paresthesias. So this is your, again, patient coming into the emergency department with some type of trauma. And again, what's a dangerous mechanism of injury? What's dangerous to a 20-year-old might not always be dangerous to a 70-year-old. And again, that's why they have the age stratification in there. But it's considered to be dangerous if there's a fall from a height of 3 feet or 5 steps, or an axial load to the head. So think of somebody diving into a swimming pool, or any motor vehicle collision at a high speed, or collision involving some type of motorized recreational vehicle or a bicycle collision. So we get the idea. Anytime there's an external force that hurts, that's a dangerous mechanism of injury. So those people then are going to get radiographs. The next question then is, are there any, if the patient looks good, they look low risk, are there any low risk factors that allow us for having the patient perform safe assessment of range of motion? Because that's typically what we do, right? We talk to the patient first, and then we say, let me see you move. We want to see what they're willing and able to do. So you're not going to ask a trauma patient to do that unless they look low risk. So low risk would be, first of all, the mechanism of injury didn't seem that bad. Maybe it was just they were on a boat and they hit a wave and they got a little whiplash. So again, it depends on the patient. Your patient's sitting normally, walking around. There's not a whole lot of neck pain. There's an absence of that midline cervical spine tenderness. If the patient looks like that, then yes, we can safely assess his range of motion and go to the third question. But if the patient doesn't look like any of that, if he doesn't look low risk, he's going to get radiographs. Now, let's say your patient did look fine. They're walking around. They're impatient because they've been waiting for a couple hours in the emergency department. We are going to get them x-rays. If they're low risk, we're going to go ahead and let them rotate their neck. And if they can rotate 45 degrees, they don't need x-rays. If they can't rotate 45 degrees, they're going to get x-rays. So again, it's a little unwieldy to navigate. It's been a barrier to emergency departments adopting the Canadian cervical spine rule. But again, with the physical therapy assessment, when we have the patient in front of us one-on-one and we have the time to assess them, we can certainly apply this rule.